Hello, everyone. Welcome to Group 4's presentation on the analysis of breast invasive carcinomas using the given data from pan-cancer. The purpose of our analysis is to identify some of the factors that affect breast cancer survival and to gain insight into who's most at risk of dying of breast cancer and to locate the genes that contribute to the development of breast cancer. For our data analysis, our team decided to approach the project using the following main techniques learned from the lectures: survival analysis and PCA. To begin, our team performed survival analysis according to the specific patient characteristics, such as race, tumor stage, radiation therapy, and age group. To do this, we modified the clinical patient dataset and extracted the columns of interest. Next, our team used the principal component analysis to identify potential genes for therapeutics. Our team extracted tumor references and alternate count information and correlated each to the specific Hugo symbol or gene. Using the largest absolute magnitude of rotation values of PC1, our team then identified the top 5 genes for potential therapeutic targeting. Additional literature research on said genes was then conducted to evaluate the strength of therapeutic potential.
We first performed survival analysis on the clinical patient data obtained from the pan-cancer database, which had clinical patient data from 1,804 Americans diagnosed with breast cancer. We did 4 separate survival analysis plots examining the 4 main factors seen here. Firstly, let's look at age and race. For the age-based survival analysis, we grouped the patients by decade. So group 2 is age ranges 20 to 30, group 3 is ranges 30 to 40, and so on. From the survival graph, breast cancer survival length is around 280 months, or about 23 years for age group 4, or 40 to 50, and age group 5, 50 to 60. Generally, as the age increases, the survival length decreases. Approximately 68% of women aged 80 to 90 are estimated to have a survival time of fewer than 50 months. One notable exception is age group 2, 20 to 30 years old, which has a much lower survival time. This is because although breast cancer is uncommon among individuals in that age group, those that do have it often have more aggressive forms of the illness, which explains this disparity. As for racial trends, white Americans have the longest cancer survival length, which is also around the 280-month mark. That is followed closely by Black Americans, Asian, American Indian, and Alaska Natives. Although the steep drop in the Native American and the Alaska Native survival analysis indicates that the sample size is too low for conclusive results. This is notable, especially since white Americans actually have the highest rate of breast cancer diagnosis in the database, followed by Black Americans, Asian, American Indian, and Alaska Natives. These trends could be due to socioeconomic factors, but could also indicate a genetic disposition among certain races and merits further research.
Regarding to the radiation therapy impact on survival rate, it is an effective treatment method for breast cancer. By analyzing figures, we can identify patients who have had radiation therapy have a greater survival probability than those without radiation therapy. This is denoted by the radiation therapy trend line, which is a green line that has a wider distribution in the time direction, showing that those that have undergone radiation therapy live longer than those who have not undergone radiation therapy prior. The final survival analysis is about tumor stage variation. The classification of tumor stages currently used is based on prognostic factors. Most tumors are diagnosed at an advanced stage, thus the survival rate is substantially poor. Most notably, patients at the Stage 4 are commonly determined to have reached a stage where their cancer can no longer be cured. However, the survival analysis shows that Stage 4 patients can also survive relatively longer than after diagnosis. This is due to the advancements in surgical therapy, which has increased the lifespan of patients with metastatic breast cancer, which usually occurs at the final stage with stage 4.
Moving forward, our group performed PCA analysis on the mutations dataset, analyzing the tumor reference and alternate counts with the Hugo symbol or their gene names. We focused on PC1 since it comprised of the most variation in the dataset. From there, we found the top 5 genes with the largest magnitudes or their loading scores to analyze their potential as targets for breast cancer therapeutic development. We've listed these genes here. So we have TTN, MUC16, FLG, KMT2C, and FLG2. Further literature research was then conducted, and we determined that each of these genes displayed either a high mutation rate in breast cancer or played a significant role in tumor development and cancer cell proliferation, thus confirming the relevance and potential of these genes for future research. Finally, moving on to our discussion and analyzing from all of our results from survival analysis and PCA, we've arrived at the following recommendations and takeaways. Firstly, a wider resource allocation and distribution will allow for better targeting of age groups and race groups with higher expressions of breast cancer or low survival rates. Moreover, an increase in outreach programs can help to raise awareness of the positive effects of radiation therapy and even provide self-diagnosis techniques to avoid advanced or late-stage tumor prognoses. And finally, we recommend that more literature research be conducted on the genes that we have previously identified to determine their potential and effectiveness as targets for breast cancer therapeutic development in the future.
And with that, I would thank you for your time.